My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Brigham and Women's Cancer Center. Ductal carcinoma in situ is a pre-invasive form of breast cancer, if you will. Others may call it intraductal carcinoma. Some may actually call it pre-cancer, not really calling it cancer at all. What ductal carcinoma in situ is under the microscope is simply the neoplastic proliferation of cells still confined to the milk duct of the breast. By definition, these cells do not have the ability to spread or metastasize to lymph nodes or other parts of the body, and so it's considered non-invasive or non-life-threatening breast cancer. In the staging system, it is considered stage 0 breast cancer. And the challenge is that we know that if left untreated, a significant number of these lesions would likely remain inside the milk duct for that patient's lifetime and not cause a problem. The challenge, though, is that we are not able at this point in time to determine which lesions, if left untreated, would remain in situ, or which lesions have a higher likelihood of progressing to invasive breast cancer. And therefore, the standard right now is that we treat all women with DCIS to prevent progression amongst those that are predisposed to progress. Again, what number are predisposed to progress? Our best guess is probably about 50% of DCIS, if untreated, would progress, and 50% would remain in situ. However, right now we again offer treatment to all patients because we are not able to clearly define who is going to progress and who will not. So when it comes to surgical treatment, the goal is to remove those neoplastic cells from the breast with a clear margin, and the options range from lumpectomy alone, lumpectomy plus radiation therapy, or mastectomy. And the big difference between those three surgical options is in the risk of local recurrence or a second breast cancer event. The three surgical options are associated with equal survival. There is no difference in survival whether a woman has lumpectomy alone or whether a woman chooses mastectomy, again, because we are treating non-invasive breast cancer. But in women who do choose to preserve their breast, we are trying to minimize that risk of local recurrence because we know that amongst women who recur, approximately 50% of them will recur with invasive disease and 50% of them will recur with DCIS. And we've seen this consistently throughout all of the randomized trials of testing different treatment strategies for DCIS. There is always about a 50% risk of recurrence with invasion. And so really, when we think about minimizing local recurrence, that's what we're trying to minimize. We're trying to minimize the risk of invasive local recurrence amongst these women. So patient selection for lumpectomy alone, lumpectomy plus radiation or mastectomy is important. Helping women understand that the role of radiation therapy is to reduce the risk of local recurrence is important. And there are many strategies or tools available to us that to help us try to identify perhaps low risk DCIS where we could omit radiation and women would still have low rates of local recurrence. Now, having said that, even in the DCIS trials where they've tried to select low risk women, like the ECOG-Akron trial, selecting women with low grade or small lesions and widely clear margins, even in low risk DCIS, although the risk of local recurrence is lower over time, those women still do appear to benefit from radiation therapy in randomized trials. So it's really just a question of what is your risk threshold. Does a 10% risk of local recurrence at 10 years low enough for you? Or does 5% sound better? We know that radiation reduces the risk of local recurrence by about 50%. And so these are the conversations that we're having with our patients. If we perform lumpectomy alone, lumpectomy plus radiation therapy, or mastectomy, what is the risk of local recurrence in all of these settings? There is no role for routine assessment, surgical management of the axilla in patients who are undergoing lumpectomy or lumpectomy plus radiotherapy. But in patients who are undergoing mastectomy, we do routinely recommend sentinel lymph node mapping and biopsy to evaluate the axillary lymph nodes at the time of mastectomy. And the reason for this is that we know there is a small chance of upgrading to invasive cancer at the time of surgery. So amongst women with a core biopsy diagnosis of DCIS alone, there have been multiple retrospective studies from single institutions as well as large databases showing us the possibility of upgrading to invasive cancer. And that possibility on average is around 10 to 15%. So given that we know that there's a 10 to 15% chance of finding invasive cancer at surgery, if we're doing a mastectomy, we go ahead and do the sentinel lymph node mapping and biopsy procedure, because once the breast is gone, the ability to be able to go back and map the axilla and remove the sentinel lymph nodes is quite diminished. And that would leave us only with the option of lymph node dissection if we really wanted to accurately stage the axilla after a mastectomy. In the setting of breast conservation, though, lumpectomy planned alone or lumpectomy with planned radiotherapy, in those women, if invasive disease is identified at the time of lumpectomy, the breast is still intact and we can go back and evaluate the axilla with sentinel lymph node mapping and biopsy. So there is no need for us to do it amongst all patients who are having breast conservation. There are some clues that one can use to perhaps selectively use sentinel lymph node mapping and biopsy of the axilla when we're performing lumpectomy for DCIS. We know that patients who have a core biopsy diagnosis of DCIS but present with a mass lesion, either on physical exam or imaging, are more likely to upgrade to invasive cancer at the time of surgery. And therefore, in those cases, the surgeon may go ahead and do the sentinel lymph node biopsy at the time of lumpectomy. We also know that in cases with extensive microcalcifications, 5 centimeters or greater, that those women are more likely to have invasive disease at the time of surgery. And so therefore, some surgeons may elect to do the sentinel node biopsy procedure at the time of the lumpectomy in those cases as well. But in general, again, DCIS by itself, we do not expect to have metastasized to the sentinel nodes. And so we're not doing the sentinel node procedure because of the diagnosis of DCIS. We're doing the sentinel node procedure in cases where we're concerned that there actually is invasive disease there, or if we've removed the breast and they find invasive disease, then we can't go back and do the sentinel node procedure.